Hi everyone, welcome to Nurse 4526, week 3. This week's all about cardiac monitoring. Make sure you have your week 3 handout visible and ready to use. We will be using it for both sections, part 1 and part 2. Part 1 is going to give you a general overview of the cardiac conduction system. We're going to start looking at rhythm interpretation and looking at sinus mechanisms. This is a great 4-page article by a nurse in Nursing Times on the cardiac system, anatomy and physiology. Make sure you review this. I will not be reviewing the normal anatomy and physiology of the cardiac system or the heart because this is something that you should already know. So this is very important that you read this 4-page overview. It will be on your first test. So let's start off by looking at the cardiac normal conduction system. So we need to start with depolarization and repolarization. So the cardiac rhythm, or the cardiac heartbeat, begins with a normal electrical stimulation of the heart. The electrical stimulation comes from the depolarization and the repolarization process. You might remember this from the action potential. This process produces a rhythmic contraction of the myocardium, which is the heart muscle, which is a heartbeat. So back to basic electrophysiology and depolarization and repolarization. So in a cardiac cell, there are two primary chemicals that provide the electrical charges. You have sodium, which is on the outside, and potassium on the inside. In the resting state, the potassium, as I said, is in the inside, but it is a positive ion, but it's not as strong as sodium, which is on the outside. So the potassium is surrounded by stronger extracellular sodium. So this results in a negatively charged cell at rest. When depolarized, so when there's an electrical stimulus, or you can think of the action potential, the sodium and potassium switch through the sodium-potassium pump. So when depolarized, the interior of the cell becomes positively charged with sodium, and the cardiac cell will contract. Each cell membrane changes its permeability and allows sodium to move rapidly into the cell, making the inside of the cell positive compared to the outside of the cell. This is called depolarization, and the cell contracts. So you've almost got two mechanisms here. You've got your electrical mechanism and you've got your mechanical mechanism of the contraction. Repolarization is going back to the resting state. So you have potassium coming back into the cell, sodium going back out to the cell, and this is called repolarization. So that is just your basic electrophysiology. So you can kind of understand why we're so concerned about high levels of potassium and low levels of potassium in the cardiac system. Because if you've got too much potassium inside the cell, hyperkalemia, it can cause standstill, asystole. And not enough potassium inside the cell can cause a lot of arrhythmias. And so it's just really important to understand this is why we are so important, why we're so fixated on potassium when it comes to cardiac rhythms. So let's look at the conduction system. And this is where you'll need to pull out your week 3 handout because the first page, I want you to label the conduction system. So the electrical impulse starts in the SA node, the sinoatrial node. It's located in the upper part of the right atrium. This is where the pulse starts, or the electrical activity starts in every heartbeat. And so you've got this electrical stimulus going through the right atrium, over to the left atrium, and also down to this area here, which is called the atrioventricular node. This is your gateway, your passageway into the ventricles. There's actually a pause that happens here. You can see kind of this, it's called a bundle of His, but it allows for this AV bundle, sometimes it's called. So it's the AV bundle is the AV node in the bundle of His, allows for a little bit of a pause because you want to make sure that the atria have expelled all the blood contents before you have this pumping going on. So the electrical impulse travels to the AV node, down through the bundle of His, down through the right down through the left, bundle branch blocks, and up through this side, which is the Purkinje system. So the Purkinje system are these fibers coming up the outside of the ventricle. So you can read this here. Electrical impulse spreads from the sinus node throughout the left and right atria, causing the atria to contract and expel its volume of blood into the ventricles. Here, the electrical impulse spreads from the bundle branches through the left and right ventricles, which causes the ventricles to contract, forcing them to expel their volume of blood out into the general circulation. So this is all happening because of that whole repolarization and depolarization. So make sure you pause this and make sure you have a good understanding of the different parts of the conduction system. So I just want to start by telling you that the SA node is the pacemaker cell of the heart, and it beats at 60 to 100 beats a minute. And that's why basically our resting heart rate is 60 to 100 beats a minute. And again, when it's resting, remember that there's intracellular potassium and extracellular sodium. That's the resting state. So in a little bit more detail, let's go through this again. So this is how the normal conduction process begins. So the electrical charge occurs within the SA node when sodium ions enter the cells and potassium ions leak out. The cells are now positively charged, which the electrical part of the heart is going through depolarization. The electrical impulse travels from the SA node cell to cell, and it causes a right and left atrial contraction. So this is the mechanical part. Then the impulse travels to the AV node. The AV node sends an impulse through the bundle of His, both right and left branches of the bundle branches, through the Purkinje fibers, and then you have a right and left ventricular contraction. The cells recover, potassium returns to the cell, sodium moves out, and you have repolarization. This will all make sense when we start looking at our rhythm strips. So it's really important that you understand this normal conduction. So I'm going to give you an overview, I just have to start at the beginning, of this in a video that shows you the conduction system as well.
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium, near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium.
So let's look a little bit at cardiac cells because they're very different from other cells in the body. So they have 4 specific characteristics. They have automaticity, which is the ability to create an impulse outside of stimulation, meaning that there may be an impulse coming from outside of the SA node. Conductivity is the ability to pass the impulse to other cells. Excitability, ability to respond to a stimulus with repolarization. And contractility, the ability to contract. So you can see how these cardiac cells have unique features that maybe the pulmonary cells do not have. So what this means is that other cardiac cells can become the pacemaker if the SA node fails. So this is important when you start to look at rhythm interpretation. Failure in any part of the conduction system will result in a variation in the conduction. Hence, when we get our arrhythmias, and which you will be learning about today. So it's very important to understand these unique features that the cardiac cells have. So, as I've said before, the SA node is the pacemaker cell, and the SA node sets the rate of the heart at 60 to 100 beats a minute. But if it gets knocked out, then the AV node picks up, and you have their rate at 40 to 60 beats a minute, and the ventricle's rate is 20 to 40 beats per minute. So, if the ventricles become the pacemaker, this is a problem. So now we're going to move into looking at the electrocardiogram. So as you can see on the bottom picture here, this is what an EKG looks like. So electrocardiogram, other people will call it the 12-lead EKG. Some people call it the 12-lead ECG. And it measures and records information from 12 different areas of the heart via electrodes placed on the skin. So you can have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 along here, and then some other areas that aren't shown. So typically when you put the electrodes on the heart, you're putting 12 electrodes on the heart. Telemetry up here, this is a typical telemetry strip. Telemetry is a portable device that continuously monitors the client's electrocardiogram, and it automatically transmits its information to a central monitor. So you'll see people walking around with a telemetry pack. Typically you just see one lead on the monitor, but you can switch it to look at other leads. So this is what we're going to be learning about in this class, is how to read this rhythm strip, not the 12-lead ECG. So just a little bit about the electrocardiogram. On the left, it does provide information about the orientation of the heart and the chest, any conduction disturbances, the electrical effects of medications and electrolytes, how big the cardiac muscle is, so the mass of the cardiac muscle, the presence of ischemic changes, maybe through angina or an MI. So those are all the things that you can actually find out from a 12-lead ECG. Not so much from a telemetry strip, some of them, but not so much. But the 12-lead ECG, yes. On the right it does not provide information about the mechanical or the contractile conduction of the heart, meaning you can't evaluate the ECG, use the ECG to evaluate a patient's pulse or blood pressure. So remember, cardiac monitoring systems are not fail-proof. The nurse must frequently assess all monitored clients for signs and symptoms of cardiac instability. For example, chest pain, hypotension, tachycardia, arrhythmias. Because many nurses work on telemetry units, it's important to understand lead placement. And the lead placement I'm teaching you here is the 5-lead system, which is used for telemetry, not the 12-lead system. So you place the electrodes on the skin and attach to the monitor cable as indicated here. So right atrium will be the white, which is on the right. You attach the upper right arm or the chest. The left atrium is on the left, so you attach to the left upper arm or the left chest. The right leg you can attach to the right lower leg or the right lower chest, which is typically where you would put it. And the left leg you attach to the left leg or the lower chest. Typically you apply them all to the chest, but if for some reason, if you have a man who has a very hairy chest, you might want to move it to the left arm or the right arm. So that's where the lead system goes. So when you're when you're putting the leads on, you want to explain to the patient, you want to explain the procedure to the patient, and an attempt to calm their anxiety, because they're going to think, oh my goodness, what's happening? Why are you putting all these leads on me? Prepare the skin on the chest for electrical attachment. Cleanse the area with alcohol to remove dirt and oils. You may need to shave the area if necessary. Place the electricals on the skin and attach to the monitor cable as indicated. So this is just a helpful mnemonic on the left side. So white is right, black is opposite, snow over trees, which means you're putting the green here, white's going to go over the green, so snow over trees, smoke over fire, black over red, and brown lies close to the heart. So let's look at the ECG paper. So it's actually, you measure this rhythm strip by looking at this ECG paper. Every single ECG paper is identical. So here you have a small box. A small box, so we're looking at the duration and the time. So a small box is always 0.2 seconds. This small box here. Well, I guess we could call it a large box here. So the large box here is always 0.2 seconds and it's always 0.5 millivolts high. So in a rhythm strip, if each large square here is 0.2 seconds, and you can see that there's 5 small little boxes in each one of these large boxes. So that means each little box is 0.04 seconds of time. So you really have to remember this when you are calculating the duration of these different spikes and P waves and T waves, which you'll learn about on the ECG paper. So again, the large box is 0.2 seconds. Each large box is comprised of 5 small boxes, and so that means that each tiny little box is 0.04 seconds of time. So this is what you're going to be learning about, and I'm going to walk you through the different parts of the cycle. So you can see this is where your depolarization is starting to come into play now. And you can see this is where the contraction is starting to happen. So ventricular and atrial systole is atrial contraction. So I'm going to walk you through each part of this ECG tracing. Okay. This is just a broad overview of the cardiac cycle, and then we're going to go into detail. So the first part is the P wave. And remember I talked about the SA node? So atrial depolarization is what makes this P wave. It's initiated by the SA node and it causes the P wave. So that's our first part. Remember the AV node? So with atrial depolarization, complete, the impulse is delayed at the AV node. So that's that little wee flat line here before it goes into this complex. So you've got the P wave happening because that's atrial depolarization, and you've got contraction. You've got that a little bit of a delay. Remember I talked about the delay. The AV node causes this little bit of a delay in here. And this QRS complex is ventricular depolarization, when the ventricle contracts. So ventricular depolarization begins at the apex. Remember, at the bottom of the heart, it goes down through the left and right bundle branches, and it causes the QRS complex. So this is ventricular depolarization or ventricular contraction. At the same time that this is happening, the atria are relaxing and they're going back into repolarization, into their resting state. This little flat line here is depolarization, so the resting part of the heart. And then this T wave here is when the ventricles start to relax and repolarizing. And that's when you get the T wave. And then you get your flat line again. To start all over again is when the ventriculars repolarize. So remember, the whole part about the depolarization is the contraction part, or systole, and the ventricular depolarization is contraction or systole. And then both atria and ventricle have repolarization when you go into the resting states. So again, this is very important to understand when you're looking at this rhythm strip. So again, I'm going to go into a little bit more detail. So, but before I do that, I'm going to play this video again.
Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
So that video went into a little bit more detail about the individual specifics about the Q, the R, and the S. What I want you to understand is this the whole complex, the QRS complex all together, and that it's ventricular depolarization or ventricular systole or contraction. Next up, I'm going to go into each of the waveforms individually again. So remember that the P waves are the conduction from the SA node through the atria, and it causes atrial contraction. So atrial contraction or depolarization gives rise to the P wave, and it represents atrial depolarization. So that's the first wave. The QRS complex here is the conduction from the AV node down the bundle of His to the Purkinje fibers, so down the right and left bundle branches to the Purkinje fibers, which extend along the lateral walls of the ventricles, and it gives rise to the ventricular contraction or ventricular systole, and that causes the QRS. The T wave represents ventricular repolarization. And so again, repolarization is the resting state or the relaxation of the ventricles before the next P wave happens again, and the whole cycle repeats itself. Okay, so let's start looking at some of the fun stuff, the cardiac rhythms, determining the heart rate and rhythm. This might be a good place to stop and take a break before we move into this piece. So remember the rhythm strip. Remember I said that each large box is 0.2 seconds. Each of the tiny little boxes is 0.04 seconds. Typically when you read a strip, you take a 6-second strip. And rhythm strips will record the strip when you print it out with these markers. And these markers represent a 6-second strip. This one actually has markers at the midpoint, which is a 3-second strip. So if I were to count all these boxes along here, in order for me to get a 3-second strip, it would be 15 of these large boxes. So 15 times 0.2 is 3 seconds. So in a large strip, a 6-second strip would be 30 boxes times 0.2 seconds, but the markings are always there. So the 6-second strip is an example of what is printed when the client is being monitored. The lines you see on the ECG paper mark 3 seconds of the 6-second strip. In this example, there are two 3-second marks, which equals a 6-second strip. The assessment of the strip is done every shift per protocol, or PRN, if the client is experiencing an arrhythmia. So this is how you start off with your systematic rhythm interpretation. The first thing you want to do is determine the rate of the 6-second strip, and I'll teach you how to do that. You want to look at, is the rate normal, slow, or fast? And you're going to learn about sinus, bradycardia, and tachycardia. You're going to determine the rhythm. Is it regular or irregular? You're going to identify an example waveform. So is there a P? Is there a QRS? Is there a T? And then you're going to analyze the findings. And remember, each rhythm has unique characteristics. So let's start off by determining the rate. So when you determine the rate, you're looking at the R waves or the QRS. So you're multiplying the number of R waves by 10, because if you think about a 6-second strip, there are 10 6 seconds in a minute. So you want to find out the rate per minute. And so you multiply the number of R waves in the 6-second strip by 10 to give you a minute. So in this diagram, or in this strip here, if you count the number of R waves, 1, 2, 3, 4, 5, 6, 7, we have 7 R waves in a 6-second strip. Let's multiply it by 10 to give us our beats per minute, so we can see that in this strip, the heart rate is 70 beats per minute. So let's think about number 2. Is the rate normal, slow, or fast? Well, if it's normal, we know the SA rate is firing at 60 to 100 beats a minute, and it's the normal pacemaker site or cell of the heart. And so if the rate is between 60 and 100 beats a minute, we know it's coming from the SA node, so we call that sinus rhythm. If the heart rate's less than 60, we know it's brady, which equals slow, so we call that bradycardia. And if it's above 100 beats a minute, we call that tachycardia. Now we look at the rhythm. You look to see if the rhythm is regular. So you look at the R waves. Are the R waves equal distances apart, or are they irregular? So what you do is you look at the ventricular R waves and you compare each R wave along here. And I'm going to give you a trick on how to do that. So when you work on a telemetry unit, you may use calibers. And what you would do is you would take the difference between two of the R to R, and then you would measure your calibers along here to see if they're all regular. Or what you can do is take a simple piece of paper, mark off the R waves here, and you can move this piece of paper along to see if the R waves are all regular. So I've got a video here that's going to show you how to mark the regularity with a paper. Sorry,
Sure.
I'm going to go along to this part where I want you to watch it. Let's look right here.
An example N. Okay. So we're going to take a paper and mark with a marker every corresponding to every QRS complexes, and we're gonna move this piece of paper like this. Okay, like this, right? So here we see in the first 3 QRS complexes it was corresponding exactly with the black lines, but as we move the paper, we see here, okay, this is not coinciding at all. Do you see that? Okay, so what does that mean? It means that the QRS complexes, every QRS complexes is not equidistant to each other. You can use a ruler or a divider or whatever to say that this is not rhythmic. Okay, or you can also simply count the number of boxes between the QRS complexes to say the regularity.
So number 4 is identifying and examining the waveform. So we're looking at the P, the QRS, and the T wave. So you look on the rhythm strip, is there a P wave? And your answer would be, if it's correct, yes, there is a P wave before each QRS. So here you can see P, P wave, P wave, P wave, P wave. Is there a QRS complex? Is there a QRS complex following the P wave? Yes, 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 yes. And is there a T wave after every QRS? Yes, there is. So that's a normal waveform. So then we go into analyzing the findings. So we know that our heart rate was 70 beats per minute, and that's normal. We used our piece of paper, and we can map along here to see that, yes, the rhythm is regular, and we can see that all waveforms are present. So the P, the QRS, and the T for every complex is present. So that is a sinus rhythm. That is a normal sinus rhythm. If there are any missing waveforms or the heartbeat is not 60 to 100 beats a minute, then there is some type of arrhythmia. And that's going to be coming up, more to come on analyzing arrhythmias. So now I'm going to add in something else. We're going to look at analyzing the conduction system with respect to time it takes for the impulse to go through the heart. So let's look at the time it takes for the stimulation or the impulse to travel through the conduction system. A delay in any of the intervals represents a block in the conduction system. So remember the ECG paper and how you figure out timing. Remember that each large box is 0.2 seconds. Each of the tiny little boxes within the 0.2 seconds, there's 5 of them, and they are 0.04 seconds. So this is really important. These are simple facts to get you started as we look at the conduction times on a strip. So these are two intervals that are really important to know. The PR interval is the beginning of the P wave to the beginning of the QRS. This is called the PR interval. And so what you would do to figure out the distance here is to count the number of little boxes between the beginning of the P wave to the beginning of the QRS. So in the above example, there are 3 little boxes. So 3 times 0.04 equals 0.12 seconds. And this is within normal range of 0.12 to 0.20 seconds for the PR interval. And again, the PR interval is the time from the SA node to the AV node. And any delay in there, if it's greater than 0.2 seconds, represents a block in the atrial conduction. The other interval that's important to know is the QRS interval. So again, for the QRS interval, you count the number of little boxes between the beginning of the QRS to the end of the QRS. In the above example, there are 2 small boxes. So you would count 2 times 0.04 equals 0.08 seconds. And so this is within the normal QRR interval of 0.06 to 0.12 seconds. So you have to memorize the normal intervals. And so the QRS interval is the time from the AV node through the bundle of His to the right and left bundle branches to the Purkinje system. Any delay represents a block in ventricular conduction. So why is this important? An increase in the normal interval time is an increase in the time it takes the electrical impulse to travel through the conduction system. A delay in the intervals is referred to as a block. Some blocks are asymptomatic and others require immediate intervention. As the blocks increase in time, there is greater disconnect between the P waves and the QRS. Clients can become symptomatic when the heart rate increases or decreases and results in a decrease in perfusion, hence cardiac output. The last area that I want to bring your attention to is the ST segment. It is that flat line here between the end of the QRS and the beginning of the T wave would be over here. So the ST segment represents the end of ventricular depolarization and the beginning or the recovery of the ventricles in repolarization. The ST segment is very important when looking at injury. If you have a depression of the ST segment, that typically indicates myocardial ischemia, so a MI or a heart attack, or digoxin toxicity when you have an ST depression. An ST elevation indicates myocardial injury, which is angina. So that's the difference between angina on an ECG and an MI. MI is depression, which is very important, and angina is elevation. It represents injury. Very important. The NCLEX loves things like this. So in summary, this is just giving you a really good overview of everything that I've talked about. What happens with the P wave, what happens with the QRS wave, what happens with the T waves, looking at these PR segments, looking at this ST segment. And so this is a really good overview of everything that I've talked about with respect to all the key parts on the EKG or the rhythm strip. So let's look at analyzing cardiac rhythms, specifically the sinus rhythms that we've already talked about. So remember sinus rhythm. So normal sinus rhythm is what we have been using in our examples. It's when the heart rate is normal between 60 to 100 beats a minute and the rhythm is regular. In addition, there's a P wave before each QRS, a T wave following the QRS, and the intervals, the PR and the QRS interval, are within normal range. So remember the normal ranges of the PR and the QRS. Sinus rhythm is actually the only normal rhythm. And so this is your baseline. And this is how I want you to read each rhythm using these ECG characteristics. So this box is going to be your go-to of what you're going to look for. So let's discuss cardiac arrhythmias. They're also known as dysrhythmias, and they're alterations in the normal electrical stimulation of the heart. There are many causes for cardiac arrhythmias. They can be benign or they can have lethal consequences. A unique fact about cardiac muscle cells is that they can act or fire an impulse without stimulation. Remember, we talked about automaticity. Ectopic pacemakers, so outside of the normal rhythm, outside of the normal SA node, can take over the main pacemaker or cause irregular or premature beats. An arrhythmia can be as simple as the heart rate being too slow or too fast. The remaining strips that we're going to discuss are considered arrhythmias. Let's begin with sinus bradycardia. So sinus bradycardia is sinus because there is a P wave before each QRS complex, and the conduction intervals are within normal range. The only difference between this strip and the normal sinus rhythm strip is that the rate is below 60 beats a minute. So if we were to count here, this is our 6-second strip, 1, 2, 3, 4. 40 beats a minute, so it's under 60 beats a minute. It is regular. If we were to take our calibers or our piece of paper, there's a P wave before each QRS. If we look at the PR interval and measure it, it's going to be between 0.12 and 0.2 seconds, and the QR interval is going to be between 0.06 and 0.12. And we're going to do more rhythm strip interpretations by actually counting out the PR interval and the QR interval. But just for this, it's important just to understand sinus bradycardia. So what causes it? Well, it can occur in adults and children during sleep, which is normal. It's common in well-conditioned athletes, but it is a common arrhythmia associated with acute myocardial infarction, so MIs. And it can also happen with vagal stimulation through coughing, vomiting, straining to have a bowel movement, sudden exposure of the face to cool water, and actually carotid sinus pressure. If there's pressure on the carotid sinus or the carotid artery, you can actually cause a vagal stimulation. So what are you going to do? Well, first thing you're going to do is assess your patient. Is your patient symptomatic? And symptoms occur when the rate decreases to a point where there's a decreased cardiac output resulting in decreased perfusion. So what are you going to see? You're going to see classic symptoms of decreased cardiac output. There may be short of breath, altered level of consciousness, syncope, pre-syncopes that you're becoming dizzy but you don't faint. Syncope is fainting. Weakness, chest pain, hypotension. These are all indications of decreased cardiac output. What are you going to do about it? Well, if the patient's not symptomatic, you're going to monitor and you're not going to do anything about it. Maybe their heart rate is normal. Maybe they're sleeping. Maybe they're an athlete. But if they are symptomatic because of the slow heart rate, treatment may include checking their pulse to see what their saturation is. You may end up giving supplemental oxygen if their saturation is low. You probably want to get IV access because you're thinking that you may need to give a drug. You're going to obtain a 12-lead ECG, and you may be giving a drug for bradycardia, which is atropine. So what's atropine? It's a vagolytic. Remember I talked about the vagus stimulation? So it blocks the chemicals at the ending of the vagus nerve. When you stimulate the vagus nerve, it causes bradycardia. It stimulates the parasympathetic nervous system. So if you block the parasympathetic nervous system, you're going to get more sympathetic activity. And so the rate at which the SA node can fire is increased, and it increases the speed of conduction through the AV node. Now, this is kind of like a band-aid because you need to figure out what the underlying reason is for the bradycardia. But this is typically your go-to drug for a symptomatic bradycardia. So this is one of your ACLS drugs, advanced cardiac life support drugs. The next arrhythmia is sinus tachycardia. So sinus tachycardia is sinus because there's a P wave before each QRS complex, and the conduction intervals are with normal range. So in this one, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So the rate is 130 beats a minute. The rhythm is regular if you were to get out your calipers or your piece of paper. There's a P wave before each QRS, and if we were to measure the PR and the QRS interval, it would be within normal range. So what causes it? Well, there's a lot of things that causes it, but the heart rate increases when there's an increased need for cardiac output. So it's a response mechanism for something that's going on within the body. So some of the things that could be a decreased blood volume, so hypovolemia, maybe they're dehydrated, so the heart's got to beat faster to get that cardiac output out. Respiratory distress, fever, pain, anxiety, and some medications. And so again, the heart rate increases when there is a need for increased cardiac output, and it's in response to some of these are some of the causes. So what do I do about it? You always treat the underlying cause. So clients with sinus tachycardia are at a higher rate for coronary artery disease because of the increased myocardial oxygen demand and the resulting decreased diastolic filling. So it's really important that you figure out what's happening with this patient. So you're going to treat the underlying cause. Do we need a blood transfusion? Do we need fluid replacement? Are they dehydrated? Are they in pain? Are we giving them some type of medication or a substance that's causing this to happen? Do we need to reduce a fever or anxiety? Do they have a pneumonia? Do they have a urinary tract infection? So again, you always treat the underlying cause because if the clients continue with sinus tachycardia, as I've said, they're at a higher risk for coronary artery disease because of that constant increased myocardial oxygen demand. And the heart is not pumping properly, so you have decreased diastolic filling. So you're not getting that rich oxygenated blood through the coronary arteries to the cardiac muscle that needs it. So you could lead to angina or a heart attack. And just to remember that safety is a priority with both these arrhythmias. A heart rate that's too fast or too slow can cause decreased perfusion. And a decreased perfusion can lead to syncope and a risk of fall. So it's very important to think about implementing falls protocols if a client is sinus bradycardic or sinus tachycardic. So that's the end of part 1. I wanted to go through just the sinus rhythms and sinus arrhythmias. Up next, we're going to look at atrial arrhythmias, ventricular arrhythmias, asystole, and the difference between cardioversion and defibrillation. But just one last thing is that sometimes you can get artifacts on your rhythm strip, and it's important to look at that because you may think it's an arrhythmia when in actual fact there's something happening with your electrodes or your cardiac monitor. And so artifact is distortion of an ECG tracing by electrical activity that is non-cardiac in nature, and it can mimic can mimic various cardiac arrhythmias. And so it's very important that you evaluate your patient before initiating any medical intervention. So some of the causes could be loose electrodes, broken ECG cables or broken wires. Maybe there's a muscle tremor, patient movement, external chest compressions. If you're doing CPR, you may actually think that you're actually getting a heart rate when actually it's just the external chest compressions through CPR. And so these are just some examples. This is loose electrodes. So you can see that the contact is not there between the skin and the electrode, and you're getting this wonky rhythm. And you could think that something is terrible happening with your patient when in fact it's not. So always good to not assume that it's loose electrodes. You run into the patient to make sure that they're okay. And this is a muscle tremor. And so maybe the patient's shivering. And so very important to always check your patient. So I'm going to stop here and we'll go on to part 2.